My topic today is the natural history of common food allergies and why some and not others disappear. This is a topic that Dr. Len Altman proposed, which I think is a really interesting question. I really learned a lot doing this talk, so I hope you learned something as well. I'm one of the first year allergy fellows at UW. I have no disclosures. So the objectives of today's talk is to understand the natural history of some common food allergens, to recognize some of the markers that we know signal a persistent IgE-mediated food allergy, to understand our current strategies for altering the natural history of food allergies, and to consider some mechanisms for why some and not others might have higher rates of resolution. So an outline of today's presentation. So I'll go over the epidemiology of some food allergies, what we know so far, some diagnostic tests that we currently have available, and some that we're looking into, looking at the prevalence of the top 9 food allergens and what their natural history is, to look into prognostic markers associated with persistent food allergy or tolerance, and to look into secondary prevention strategies, or how can we interrupt the natural history of food allergy. And then we'll explore some ways, some reasons why food allergies might persist. In terms of epidemiology, I think we all know that food allergy is on the rise. There's 6.7 to 8% of children in the US with food allergy. The prevalence of top food allergens I found from my reading really does vary by country and how much each food is consumed by people in the country. Overall, we do know that there is a higher persistence of peanut, tree nut, and seafood allergies, more so than milk and egg. Overall, food allergy is a really significant burden for patients, for their families, schools, their communities, and healthcare. It really reduces their quality of life due to isolation and restriction. And it's very costly. So an estimated 25 billion a year is attributed to those with food allergy in the US, which I thought was pretty shocking. So in terms of the diagnostics, like the tools that we have now, so history, of course, is very important in determining how likely it is that a person has had an IgE-mediated food allergy. We also support this with skin prick testing and serum IgE testing, though these tests do have high false positive rates. Lately, we've been looking more into component resolved diagnostics, so looking at components of proteins that patients are sensitized to kind of help predict clinical or severity of food allergies. And then we have the gold standard, which is the oral food challenge, giving the patient the food and seeing if they react. Some in vitro assays that are in development include the basophil activation test and the mast cell activation test. So the BAT, this is a functional assay in which basophils are stimulated by an allergen and upregulated markers are measured to see if a patient is allergic to a certain allergen, and it has a very high sensitivity. Currently, it's just used in research and isn't validated or standardized for clinical use, but it's something that does have some promise. Mast cell activation tests. So for the BAT, that uses fresh blood that must be used within 24 hours, but the mast cell activation test just uses patient plasma that's mixed with mast cells, and then markers are observed after that. I think it has a bit of a lower sensitivity, though, than the basophil activation test. So this is just a general overview of some of the prognostic factors, kind of some themes I saw going along the different food allergens. What are some factors that are associated with persistence of food allergy? So having a severe reaction when you were diagnosed, what your initial markers look like. So what was your serum IgE level? How big was the whale size of your skin prick test? How fast did that change over time? Other measures that I looked at were specific IgE and IgG4. The ratio of that can potentially associate with persistent allergy. The presence of multiple food allergies is also a bad sign, as well as having comorbid atopic diseases and how severe those are, such as eczema, especially asthma and allergic rhinitis. And I did notice through looking at this that it does vary by food, so I'll go through each one. So starting with cow's milk, I'll be going through the kind of the top 9 food allergens. In terms of the prevalence of the different food allergens, I tried to focus on numbers in the US and tried to include adults where I had the numbers, but I'll kind of point out where I got the numbers as we go. In studying prevalence, it is difficult to kind of pin down what is the accurate number that we're seeing of these different allergens because a lot of them are done through surveys where patients are self-reporting allergies. However, there is some effort made to determine how likely it is based on history, if they've had skin prick testing or serum IgE, if a doctor has diagnosed them with an allergy, or if they've even gone the gold standard, which would be the oral food challenge. So for cow's milk, this is one of the most common childhood food allergies. The prevalence I saw was 0.9 to 2.6%. This allergy typically presents within the first year of life, and about 50% of this allergy will resolve by the ages of 5 to 10. These are some prognostic factors. And when I talk about prognostic factors, I'll mainly be focusing on the things that seem to be associated with persistent allergy. So in terms of cow's milk, atopic dermatitis is a risk factor, as well as young age at presentation. As you'll see in a lot of these foods, having a large skin prick size or a high serum IgE level is associated with persistence, so greater than 10 millimeters or greater than 10 kilunits per liter in milk. And then a peak serum IgE level that's very high is inversely related to how quickly a patient will acquire tolerance. So only 60% of patients with cow's milk allergy and an SIgE of 50 will outgrow their allergy by age 18. In terms of components, for casein, which is like the heat stable milk protein, high levels of that have been associated with a persistent milk allergy. In some other studies, they looked at the epitope binding of casein, so not just the component, but the different epitopes that IgE binds to, and binding to a greater diversity of epitopes is associated with persistence as well. There's also some thought that tolerance of baked milk does suggest a good prognosis for tolerance to uncooked milk. Moving on to egg, the prevalence of this is 0.5 to 1.3%, also a very common childhood food allergen. This typically presents within the first year of life, and it has a fairly good prognosis. So 50 to 89% of these food allergies will resolve by the ages of 2 to 6. This is a bit of a busy slide, but there are a lot of different things that have been looked at with egg. In terms of history, having an initially severe reaction, being young at the time, having other food allergies, especially peanut and or sesame, being allergic to baked egg, and having early onset atopic dermatitis, as well as a family history of atopy, these are all associated with a persistent egg allergy. In terms of measurements that may be predictive, so baseline serum IgE of greater than 10, a wheal greater than 10 millimeters or greater than 4 at age 1, that's associated with a persistent allergy. And then similarly, so having a high serum IgE level of 50 or more portends a pretty low chance that you'll resolve your allergy before 18. In terms of components of egg, so GALD1, which is the ovomucoid protein, that sensitization does increase the risk of a persistent allergy by 2.5 folds. But not only that, so being sensitized to multiple components, not just GALD1, but GALD2, which is the ovoalbumin, which is a much more abundant protein in egg white, as well as 3 and 5, which are in the yolk. Being sensitized to multiple components also increases your risk of persistence. And tolerance of extensively heated egg or baked egg suggests a good prognosis for developing tolerance to cooked egg. So for peanut, the prevalence is 0.7 to 5%. This is definitely rising. It presents a little bit later, around 18 months or older. And it has been known to have a more poor prognosis, so 22 to 29% resolve by the ages of 4 to 6. So early onset and severe atopic dermatitis is a risk factor for persistence, as well as being sensitized to a tree nut or other food The serum IgE level only greater than 1 is actually associated with a poor prognosis, and then greater than 3 before the age of 2. The skin prick tests greater than 8 at 1 year or greater than 6 before age 2 are also associated with persistence. And then the rate of the increased skin prick test wheal size is also associated with persistence. For components, I think we're familiar with the RH, 2, and 6, which are helpful for diagnosing, clinical or severe peanut allergy. But it's also been seen that polysensitization, so similar to some other foods where you're sensitized not only 2 and 6, but 1 and 3, that may predict persistence as well. So for tree nuts are actually a bit less well studied than peanuts and some of the other foods that are more common. This prevalence of 1 to 3% is actually a worldwide number. It is an allergy that presents a bit later, age 2 and above, and it has a fairly poor prognosis. So 9 to 14% of these allergies resolve. Some factors in terms of the patient history. So if the patient is allergic to more than 2 unrelated tree nuts, that's a poor prognostic sign, as well as having another food allergy of any kind or atopic dermatitis. Interestingly, the initial reaction history and history of asthma are not associated with a persistent allergy. So just to touch on some components and some cross-reactivity that has some implications clinically. So cashew and pistachio are known to be related, walnut and pecan as well. In terms of some studies on cross-reactivity, it's shown that 83% of cashew allergic patients will react to pistachio. And on the flip side, 97% of pistachio allergic patients will be allergic to cashew. With walnut and pecan, 75% of walnut allergic patients will react to pecan, and 97% of pecan allergic patients will react to walnut. So that's useful because in patients who have multiple food allergies, who are potentially going under OIT, oral immunotherapy, or oral challenges, knowing that they're allergic to one may save them an oral food challenge to the other if they're very closely related. And also if you're thinking about OIT or oral immunotherapy for tree nut, there's some evidence that desensitizing to one tree nut could help the patient become desensitized to others that are related or share epitopes that cross-react. And then below are some components that are related to some of these nuts that we know are associated with more systemic or severe reactions. There wasn't too much information on polysensitization or epitopes in terms of tree nuts, but that is something that would be interesting to look at. So soy, this is interesting because in the US, the prevalence of this is 0.5%, but in countries in Asia where soy is more highly consumed, that number could actually go up to 9%. This typically presents in infancy to 2 years of age, but could also develop as an adult. And the resolution rate is fairly good, so 45% by age 6 and 69% by age 10. There was less information about soy, but in terms of some of the other foods, a very high serum IgE level greater than 50 is associated with persistence and is inversely related to the rate of tolerance. In terms of components, so GlyM5 and GlyM6 are present in children who have a more severe soy allergy. But interestingly, this was a study done in Japan. GlyM4, which is the birch BET-V1 homolog, is associated with a more severe and persistent IgE-mediated allergy in adults. And I do believe they controlled for like pollen food allergy in this study. Okay, so for wheat, the prevalence of this is 0.4 to 1%. That's in children. It typically presents in infants and toddlers and has a fairly good prognosis. So 29 to 65% resolve by the ages of 4 to 12 and 76 to 96% by late teens. So these are some prognostic factors I found from a couple of studies. So it's been seen that having anaphylaxis at a younger age, so prior to age 3, is more likely to persist. Components that I looked at, so high levels of omega-5 gliadin, serum IgE, that's associated with persistence. And then just to note, the tri-A37 protein is associated with anaphylaxis. In terms of having a really high serum IgE greater than 50, patients with that number, only 40% or 40% had persistent wheat allergy at age 14. It was interesting, though, that some children outgrew their wheat allergy even with a high serum IgE, and the thought was that they potentially had cross-reactivity with grass pollen allergy. So moving on to shellfish, the prevalence in the US is about 2 to 3%. However, in countries in the like Asia and Pacific region, that number goes up quite a bit, even up to like 7%, in areas where seafood is more highly consumed. The top shellfish allergen in the US is shrimp, actually, not crab. But it's the most common allergy in adulthood, though it can present in childhood as well. And overall, this has a poor prognosis. We know that this type of allergy really tends to persist. And based on a Canadian cohort, the resolution rate over a 5-year period was 0.8% per person year. So in terms of fish, prevalence is 0.5 to 1% in the US. This does go higher in other countries. The top fish allergen in the US is salmon, I believe. And this presents typically between ages of 1 to 2. And based on that same cohort, the resolution rate of fish is low, 0.6% per person year. However, there was a study done in Greece on, it was like 58 children that they studied and followed over time and then challenged. And they had a much higher success rate, so 22 to 45% resolution by teenage years, which I thought was pretty interesting. In terms of looking at shellfish and fish, overall, the prognosis is not great. In terms of shellfish, there wasn't a lot of information on markers for tolerance because so many people have persistent allergy. I did find something that looked at some different epitope binding and component binding in shrimp allergy. And it's thought that sensitization to tropomycin may be associated with shrimp allergy persisting into adulthood. And then in terms of fish, so this came from the study done in Greece. So they found markers that were associated with persistence or a positive food challenge, were a very elevated cod, serum IgE prior to a cod challenge. And then the GAD-C1 parvalbumin protein was highly associated with a persistent food allergy. All right, so last but not least, sesame. The prevalence of this one is 0.1 to 0.2% in the US. This was more of an emerging top food allergen a couple of years ago. The rates of sesame allergy are a lot higher in the Middle East and Asia. And this typically presents at about 2 years of age and resolves by age 4 to 6 in 20 to 30% of patients. Some prognostic factors. The first bullet is talking about actually factors that predict tolerance. So actually having an earlier reaction, you're more likely to develop tolerance over time. Having a milder reaction, having fewer other food allergies, such as tree nuts, and then having a small skin prick test of less than 7 millimeters. It's also interesting that more than half of patients with sesame allergy are also allergic to peanuts or tree nuts, so it's something to look out for. And then with component testing, the SES-I1 and SES-I2 proteins are associated with severe allergy or anaphylaxis, but I didn't find any studies looking into whether these predict persistence in sesame. So this is kind of moving on to the latter half of the presentation, which is looking into interventions. And by that, I mean, what are the secondary prevention strategies that we have to alter the natural history of food allergies? How can we change the course of how food allergies persist? So I know it's early, but this is the mechanism of tolerance in the gut. So what you'll see here is the small intestine that contains the lymphoid tissue. You'll find here that macrophages are actively taking up food allergens into the gut. These macrophages will produce IL-10, which helps promote Treg development. They're also transferring antigens to the dendritic cells, CD103 positive. These particular dendritic cells then migrate to the lymph node and present their antigen. They secrete TGF-beta retinoic acid, and this promotes the development of FOXP3 positive T regulatory cells. And so while they're proliferating and doing well, they're inhibiting mast cell degranulation. And down here, you see it's shifting away from a Th2 response. So the Th2 cells are anergic or apoptotic. So this is kind of moving on to ways in which we've tried to alter the natural history of food allergy. So first I'll be talking about baked milk and baked eggs. So these are ways in which we've tried to kind of alter the protein itself to see if this can be better tolerated in patients. It's been studied that baked or extensively heated milk is safely tolerated in 75% of children who reacted to uncooked milk. Clinically, it's associated with a decreased milk skin prick test wheal size and increased casein IgG4. And then it's thought that it's possible that incorporating this into a kid's diet could hasten the development of their tolerance to uncooked milk. This is a bit controversial. I think it hasn't held up in kind of like systematic reviews, but I think anecdotally people are trying to use different ladders to help kids better tolerate uncooked milk into baked form. Similarly with extensively heated egg, this may be safely tolerated before cooked egg in 70% of children. And it's thought that incorporating this into the diet could hasten the development of tolerance to cooked egg. It is, again, unclear if these patients who end up being tolerant to cooked egg would have outgrown their egg allergy anyway, or if the baked egg is actually helping them move along. So now moving on to ways in which we can change the natural history of food allergy by altering the immune system itself. So oral immunotherapy is the induction of tolerance of hypersensitivity through regular ingestion of a food allergen. We've seen this with Palforzia for peanut allergy in ages 4 to 17. You'll have increased doses of tolerated food given to the patient, and this ultimately is supposed to help reduce their risk of accidental life-threatening reactions. So I think there are a lot of benefits to OIT. There are some risks as well. Allergic reactions, of course, if you're giving patients their allergen, as well as some risk of getting eosinophilic esophagitis. It is very time and resource intensive for families. So it could take months to years to get dose escalations up to appropriate levels. And then it's also a bit unclear at this time whether are we just desensitizing patients temporarily or are we achieving sustained unresponsiveness. So this sustained unresponsiveness is defined as the state in which an individual with a food allergy no longer requires the regular ingestion of their allergen to maintain desensitization, meaning they've stopped OIT and for a period of time, they're not taking it and then they can take the food again and not react. And this should phenotypically resemble a normal immune tolerance. The mechanism of this is not fully understood. In some kind of short-term studies, it's potentially possible in egg and peanut allergy, but we're not completely there yet in terms of having all of that data. So this is another busy diagram, but this is looking into OIT and how it kind of alters the immune system. So overall, when you're doing OIT, you're going to have an upregulation of these T cells, Tregs. And you can see they're outweighing the Th2 phenotype. So these Treg cells are telling the B cells to switch from these IgE to IgG. over here in this corner, you can see these IgG4 antibodies are outcompeting the IgE to bond to the Fc gamma receptor on mast cells and basophils. And ultimately, this leads to a decrease in the mast cell and basophil activation. And then this, again, with higher levels of Tregs, you are leading to more of an anergic apoptotic phenotype for the Th2 side, leading to more tolerance. So this is something that's been looked at. Omalizumab, an anti-IgE monoclonal antibody, alone or with OIT, has been shown to increase the tolerance of multiple food allergens, namely milk, egg, wheat, and baked milk in studies. It can help patients achieve higher doses. It can also allow for more rapid escalation of OIT doses, and overall was shown to improve quality of life in patients. So this is a really promising treatment with OIT or alone. So this is the mechanism for which omalizumab kind of fits into the OIT mechanism. So here you have your Th2 cells telling the plasma cells to secrete IgE. Then you've got your omalizumab here with your OIT that's producing Tregs. It forms this inert IgE, anti-IgE complex, kind of taking away the IgEs from the mast cells and basophils, and the Fc receptor here for IgE is downregulated. So overall, this leads to more of a shift towards Th1 and T regulatory phenotype rather than Th2. And then this reduces the allergen-mediated basophil and mast cell degranulation that is noted in allergic reactions. So some other biologic therapies that are being looked to with OIT, dupilumab, so our anti-IL-4 biologic that affects IL-4 and IL-13 signaling. I think anecdotally, it's been seen to lower serum IgE to multiple food allergens in patients who have atopic dermatitis, which is an indication for the medication. It's also FDA approved for EoE, so it's thought it may be great to use with OIT and mitigate that possible side effect of EoE. It's currently being studied as an adjunct with peanut and milk. And then below, there's another area of research in anti-alarmins. So TSLP, IL-33, IL-25, these are all cytokines that activate Th2 inflammation or pathways that go towards Th2. Icotimob is an anti-IL-33 biologic that is being studied with peanut OIT, and I know it's also being studied with atopic dermatitis. Tezepelumab, our anti-TSLP, is used for asthma as an adjunct therapy, but as far as I saw, it has not yet been used in food allergy. So another immunotherapy form is epicutaneous. So this is a patch rather than oral. It allows uptake by antigen-presenting cells in the epidermis of the allergen. It's been shown to decrease allergen-specific IgE, to increase IgG4, decrease skin prick test size in patients with peanut allergy. So epicutaneous immunotherapy was studied in 2 different age groups. There was more success in the ages 1 to 3. This actually led to higher rates of desensitization at 12 months, and did not meet this endpoint in the ages of 4 to 11, but did allow for increased tolerated dose of peanut in those patients. The side effects were fairly mild, but mild to moderate local skin reactions that didn't cause anyone to stop the patch during trials. And no oral and very few GI side effects were seen in comparison to OIT. So in summary, it seems like based on the studies, it's thought potentially this is less effective just based on the numbers that they found in research, but potentially this is an option that could have fewer side effects than OIT and maybe more applicable to the younger age group that is not eligible for, say Palforzia, which starts at age 4. There's also sublingual immunotherapy. So this is daily sublingual glycerinated allergen that's taken up by antigen-presenting cells in the oral mucosa, and similar to OIT, shifts away from the Th2 response and promotes T regulatory cells. Unsurprisingly, the side effects of this are oropharyngeal itching, but the GI side effects and systemic reactions are quite rare in SLIT. Overall, it's thought that this therapy is less robust than OIT. Patients were not able to reach as high of a tolerated dose of allergen in peanut studies. So it's a good potential therapy with fewer side effects, but may not be as effective. So this kind of brings me to the main question of this talk, which is why do some allergies persist? And in terms of understanding why, say shellfish versus egg or milk persist, I don't think we have the answer to that. I presume that there's something about the food allergy protein, the characteristics of it that leads to persistence, or something about the host that, about the patient that leads to a persistent phenotype. From reading about all these different food allergies, I did note that like the prevalence and the persistent rates seem to vary regionally and by country. And we really do need further studies looking at different food allergy protein characteristics to help us understand what are the mechanisms of persistence. Based on a few studies, it's possible that a greater diversity of component sensitization and epitope binding may coincide with persistence. And this eventually may help us better characterize and have biomarkers for different allergy phenotypes, different allergens. In terms of why patients are persistently sensitive, based on the mechanisms we looked at, it's some sort of disruption of normal tolerance to food proteins that persists, and an inability to down-regulate Th2 response. And based on somewhat understanding these mechanisms, we tried to intervene with these secondary interventions like OIT. Currently, there's not too many markers to predict persistence of food allergy, and that's an area of future interest. So currently we know, certain atopic comorbidities, high serum IgE, really big SPT size, and different components can help us sort of understand what patients might have persistent allergy down the road. But kind of looking into the future, so I think definitely looking into biomarkers will be helpful. So components we're already looking into now. Currently, we're using them to help predict the clinical presence and severity of several different food allergens, but it's also a promising way to kind of predict food allergy phenotypes, whether that be like polysensitization to different components or particular ones that are associated with persistent allergy. That's been seen in peanut and egg. And then epitope mapping. So this is kind of a more granular look at components. So not just the components, but the different epitopes of the protein and how IgE and IgG4 bind to those, could help really understand how different patients are hanging on to their allergen. And in a study on peanut allergy, it was found that that information could actually add predictive value to the serum IgE in diagnosing peanut allergy. But I also think that looking at epitope binding, how diverse and how avid the antibodies are binding to protein could also further characterize allergy phenotypes. And this has been seen in milk allergy. And then lastly, basophil activation testing, which we looked at before. Though it's currently used in research, it could be a really clinically useful tool in predicting tolerance in patients who are going under OIT. It's so sensitive that it's even thought that it could potentially take the place of an oral food challenge in some cases, like a safe alternative. But that's still being developed in the clinical setting. So in summary, we know that food allergies are rising in prevalence, and some are more persistent than others for unclear reasons at this time. The strategies that we have to alter the natural history of food allergies include potentially altering the protein itself by heating, using oral immunotherapy, epicutaneous immunotherapy, or sublingual immunotherapy, and then adding on biologics to those, to OIT, to help patients tolerate higher doses and have more rapid escalation of their doses. But I think ultimately biomarkers and more evidence is needed to predict the persistence of food allergy, as these are currently limited, and we would need these in order to better characterize different food allergy phenotypes in the future. So I will take any questions. Thanks for listening. And this is the word of the day, reaction.
Since nobody else is asking a question, I had to step away for a minute, but I was reading about a toothpaste that they're using for people that are peanut sensitive, and they've been able to develop tolerance after using this for up to a year. Have you seen any more literature about that?
No, that's very interesting. I did not come across anything about toothpaste, but I guess that would be some form of oral tolerance mechanism.
Yeah, they supposedly could get up to 15 peanuts after a year by
Oh, wow.
using this peanut flavored toothpaste every day.
I will have to look into that.
I just wondered if in your reading you had come across any more about that, because that was fascinating to me that you could maybe brush your kids with the teeth with the food they're allergic to and see what happens.
Yeah. No, I didn't see anything on that.
Thanks.
Did everyone get the word of the day? I can put it back up. All right. Well, thank you for listening. I think we have a couple of case presentations coming up, but I'm not sure if that's on a separate link.